Hi, I'm Jill Foose, and welcome to Afterpause. This podcast is for the woman who has made it through menopause and is ready to own what comes next. The woman who refuses to disappear, who still wants optimal health, energy, strength, power, great sex, confidence, style, beautiful hair and skin, and the next 20 to 30 years of her life to actually feel like living and knows she deserves every bit of it. This is Afterpause, and it's just getting good. Every episode is a real conversation built around one goal, telling you exactly what to do next. No guesswork, no noise, just clarity, direction, and action. Let's get into it. Hi, everyone, and welcome back to Afterpause. Today, we're talking about a topic that is near and dear to my heart. It's something I'm extremely passionate about and close to, and I hear about every single week from the women in our community. Hair loss in post-menopause. Over 50% of you are going to experience hair loss, significant, distressing, life-altering hair loss, and you are being dismissed about it, told it's normal, it's part of aging, it's just not that bad. When the truth is, there's more being done in hair loss medicine now than at any point in history. And my guest is someone you may remember from a previous episode where we talked about lasers and skin treatments. Dr. Omer Ibrahim is back, and this time we're going deep on hair loss. He is a board-certified dermatologist who is one of the most knowledgeable and clinically sophisticated hair loss specialists in the country. He treats hair loss every single day, and he understands the postmenopausal picture specifically. And he is going to give you the most comprehensive, honest, and actionable conversation on hair loss that Afterpause has ever had. So sit back, open your mind, and let's dive in. Hey, Dr. Omer, welcome back to Afterpause.
Hi, Jill. Good to see you. Thanks for having me again.
Yeah, it's great to have you. So last time you came on, we talked about lasers and in-office treatments for our skin, and now we're moving up to hair. And August is Hair Loss Awareness Month, and this is a topic very close to me because I've been on a hair loss journey for 30 years. And there are so many women, and especially in post-menopause, who are really experiencing that hair thinning and that excessive shedding.
Absolutely. And this is a topic and in which I am are truly specialized and I love. So I am super excited to dig in.
Yeah. So before we get to solutions, which is what everyone wants to hear about, I want
Yeah.
to make sure our listeners really understand the scale and the biology of what we're talking about here, because
Yeah.
over 50% of postmenopausal women will experience hair loss. And like I said, I'm one of them. And going through menopause is a trigger for hair loss, especially if you're predisposed to genetic hair loss or what we call androgenetic alopecia. But there are other reasons for hair loss as well, if you want to go over what some of those could be.
Absolutely. So just to get some terminology out of the way. So the word alopecia, so I get this a lot in clinic. Patients come in, they're like, I was diagnosed with alopecia. Alopecia is not in and of itself a diagnosis. So alopecia is just the medical term for hair loss. So it's a description. So there's alopecia areata, which is a
Mhm.
specific type of alopecia. There's androgenetic alopecia. Telogen effluvium that doesn't have alopecia in the name is a kind of alopecia. So the two most common ones that we see in clinic, and especially that we see in postmenopausal women, is our androgenetic alopecia, or the new term that they're trying to use now is female pattern hair loss. So
Mhm.
those can be used interchangeably, and telogen effluvium, and a lot of, or TE, and a lot of them tend to sort of they go together. So we can start with androgenetic alopecia or female pattern hair loss. This is more and I like the old name androgenetic because it tells you at least two factors that are at play
Mhm.
here. Genetics, of course, and androgens, which are hormones. So this is the classic sort of thinning of the scalp that you see in men and women, where you just see the thinning. It's more gradual over time. It is genetically predetermined. So it's a myth that, oh, it comes from the mother's side. That's absolutely not true. We actually don't know what the inheritance pattern is, but there is a genetic predisposition to it. It's hormonal, like when estrogen drops, progesterone drops, testosterone goes up. These are all sort of hormonal. So that's what androgenetic alopecia is. And we can talk about what is actually going on. But then I wanted to juxtapose that with telogen effluvium or TE. That is truly, it's most of the time, it's stress induced hair loss. This is excess shedding. So it's not like gradual thinning. That's when you start to see hair all over your pillowcase, your food, your shower, your sink, and it's abnormal amount of shedding. So we're supposed to shed about 100, max about 100, 150 hairs a day. If you don't wash every day, you might notice that on the day that you wash, it's a little bit more. That's fine. That's stuff that was supposed to be shedded anyway. But when you're going above that 150 hairs a day, that's when you're starting to notice it everywhere. That's telogen effluvium, the hair follicle. And people usually say they see the bulb at the end of it. That's exactly it. You see the long hair. It's not broken hairs. It's actually hair falling from the scalp. And that can be caused from abrupt changes in hormones. So we see that a lot, especially if there's quick transition in hormones. You see it post surgery. You see it from psychological stressors. So we see it when people have like exams or they're planning a wedding, planning a divorce, after accidents, after surgery. So we see it from physical and psychological stressors. Now, normally, and I say in the majority of people, not in everybody, in the majority of people, this is self-limited, meaning the telogen effluvium goes away, I should say the shedding normalizes, and then the hair regrows back. We used to think that, okay, everyone's hair grows back. That's totally fine. Don't worry about it. They'll send you home with like, take a vitamin and you'll be good to go. But we know that that's not true. We know that only a certain subset of people actually end up regrowing all their hair back. And then there's another subset that grows about 80% back. And then there's another subset that only ends up growing about 50, 60% back. This is why, at least in my clinic, I'm aggressive with treating telogen effluvium and not just letting it run its course. And so, what are things that prevent the hair from regrowing back? Takes us back to our original diagnosis that we talked about, androgenetic alopecia. This is where your genetics and your hormones are constantly fighting your hair, and they will do so for the rest of your life until we find a cure. And so we often see TE and androgenetic alopecia together. The diagnosis usually is TE or telogen effluvium unmasking androgenetic
Mm,
alopecia.
mhm,
It's all, you know how I describe it, how I compare it. It's almost like breaking your leg or breaking a bone when you're 14 or 15 versus when you're 54 or
mhm.
64. The recovery process is very different. And so when your scalp has aged, when your hair is aged, and it's gone through these hormonal changes, whatever it may be, the body evolutionarily, it sees hair nowadays, it sees hair as accessory. It won't spend resources regrowing all your hair when it needs to be taking care of other things. And
Right.
so it's truly that underlying androgenetic alopecia that we see most commonly. Even when TE is gone, that's when we see that thinning. And what is happening is we don't fully understand what's going on, but the hair is being attacked, for lack of a better term, lack of a better way to describe it. But those hormones are attacking the hair. Aging is causing an effect on the hair, and it's causing those hair follicles to shrink. So we call this follicle miniaturization. The hair follicle
Mhm.
is physically shrinking. That's why lots of people, I would say even most people that only have pure AGA or androgenic alopecia, they say, I'm not noticing any hair falling out, but why am I thinning? It's because the hair
Yeah.
follicle is shrinking. So that's how these two are distinct, but also play together a lot.
Also, isn't it true that with telogen effluvium, it's usually a few months after that
Great
stress
point.
occurs? Because
Yeah.
on my 30-year journey, even though I have androgenetic alopecia, I have had stressors. I've had the divorce. I've had, 5 babies and had hair changes after giving birth. And I've learned to keep a hair diary because when I have a big stress, a big move, or something really significant going on in my life, I know in 3 or 4 months, I'm going to have a shed.
I'm glad you brought that up because that's exactly it. And that's exactly the timing. It's 3 to 4, max 6 months, but it's usually 3 to 4 months.
You know.
That after the inciting event, then the shedding happens. And then ideally, it only lasts for 3 to 4 months in terms of the
Mhm.
shedding. But is a small subset of people where the shedding goes on longer, and we call that chronic telogen effluvium.
Right, right. You mentioned hormonal changes, and one of those hormones is dihydrotestosterone, which is this very potent androgen, DHT, and that's the primary driver of androgenetic alopecia. And this can also be a genetic component. So you can have genetic hair loss, you can also have high DHT genetically, and you can also have that 5 alpha reductase enzyme genetically be compromised. I have all three. Can you
Yeah.
explain all of these different mechanisms and how they sort of fit into the picture?
So testosterone is what we call is an androgen. And they used to call it the male hormone, but everybody has testosterone. So it is the
Right.
androgen. Testosterone itself, when it comes to hair specifically, not that big of a deal. Not that they don't interact all that much. So it needs to be converted via 5 alpha reductase to dihydrotestosterone. So dihydrotestosterone comes from testosterone, DHT, this new dihydrotestosterone. That's the bad guy. That's the one that goes and attacks your hair follicles. And how does it do that? For the DHT to communicate with the hair, they need that receptor. They need to attach onto the hair. So there are lots of people that overproduce testosterone. um, though those individuals tend to have androgenetic alopecia, but there are lots of people that actually, I would say most people that we check their hormones with androgenetic alopecia, they say, my hormones are normal. Why am I still thinning? Two reasons, at least two reasons. One, you could still be sensitive. You could have receptor or hyperandrogen sensitivity to the DHT that's already swimming around in your system. So you could be hypersensitive to the DHT.
Mhm.
And that's number one. And number two, the go-to answer is like we fully don't understand what is causing female pattern or androgenetic alopecia. We don't fully understand the mechanism. There are so many other factors and players. I would say 15, 20 years ago, it was just DHT. Now we're looking at Wnt and beta catenin and all of these other genetic and these pathways that play a role. And so DHT is a good starting answer, but it's not the full picture.
Yeah, and I wanted to talk about labs and the diagnosis for women because I think there needs to be a proper hair loss workup for women. So many times they go to a derm, obviously not you, but they go to a derm who really isn't asking questions, who isn't asking for labs to be looked at and really assessing where there might be deficiencies. And so I want every woman listening to know that she should be asking for and she should be expecting her provider to look at her labs and take her hair loss seriously and really figure out what is the root cause, what's going on with her. And so, how
Yeah.
do labs play part of that equation for you when you're diagnosing a woman who's experiencing hair loss?
That's a great question. So when it comes to labs, the age-old question is to draw labs or not to draw labs. So if a
Mhm.
patient comes in and she's in telogen effluvium, I almost always draw labs because it's acute, it's happening right now. Great time to be checking labs. With androgenetic alopecia, I take a history. I ask about diet as stressors, things like that. But if they haven't had these labs drawn, or if they haven't seen their primary doctor in a while, I will draw those labs. And for both those conditions, the labs are the same, at least from the dermatologist standpoint. And if I need more, I start with the baseline. And then if I need to go above and beyond in terms of other hormone checks and things like that, I wouldn't know what to do with it. I could order it. I wouldn't know what to do with the results. And this is where I get another physician, either gynecologist, endocrinologist, whoever it may be, on
Mhm.
board. But the baseline things that I check are, if they haven't, usually these are, a lot of them are checked at their primary doctor, but I will check the complete metabolic panel. That's where it looks at all your
Mhm.
electrolytes and things like that, complete blood count, thyroid numbers, TSH and T4. I check vitamin D levels, specifically the 25 hydroxy one. So you check vitamin D, ferritin.
Mhm.
This shows you how well you're actually using your iron stores. Zinc, because there's not a lot, but zinc deficiency. And then when it comes to hormones, I check testosterone, total
Mhm.
testosterone, free testosterone, and DHEAS. And then depending on their other symptoms, I might check an ANA or anti-nuclear pattern or anti-nuclear antibody. This is the test for lupus, but the biggest issue is that there are tons, there are probably in the millions of women walking around with positive ANAs that mean
Mm.
absolutely nothing. And that number actually can go from negative to positive. And we learn this in residency as a woman transitions from, in her 40s to postmenopause. So I don't tend to check a lot of ANA because then it just goes down a rabbit hole when
Yeah.
there are no other
Yeah.
symptoms. So those are usually the labs that I check for baseline.
And so when a woman comes in your office and she tells you she's on hormone replacement therapy, including testosterone, and she's
Yeah.
also experiencing excessive shedding, to me, that's, a light bulb moment because she might be sensitive to the DHT that's converting from the testosterone.
Exactly. And I've actually seen that before. I had a
Yeah.
patient that was on higher dose. We had to adjust the testosterone and the
Yeah.
progesterone that she was taking. It actually helped.
Yeah. And I don't think it's a dead end for that woman. Like I'm on
Mm-mm.
testosterone replacement therapy, but I balance it out with other medications to help grow my hair and
Yes.
stabilize my hair. And we're going to talk about all of that, but I don't want women to think, "Oh, if I'm already experiencing hair thinning and hair loss, I'm not a candidate for testosterone," when you might really need that as well for other reasons in your life.
Exactly. So I tell them, I mean, hair is one thing, but don't be afraid
Yeah.
of these other treatments that can help you because there are other things that we can do to actually counteract or actually work together where we
Right.
can actually knock two birds with one stone.
Exactly. Should a scalp biopsy be done as well? And if so, when is that indicated and what does it tell you that labs can't tell you?
Um, so when I decide to do a scalp biopsy is if in any way, shape, or form the diagnosis is not clear.
Hmm.
And I would tell you that in let's say percentage wise, like 1 in 10 patients, maybe to actually half a patient, let's say 5 in 100 patients, I would actually biopsy just because I do a lot of hair loss. So if the diagnosis is in any way, shape, or form unclear, then you want to do a biopsy. What does it show you? It shows you evidence of inflammation, of scarring, because there are
Hmm.
other types of autoimmune types of hair losses that, like alopecia areata, centrocentrifugal cicatricial alopecia, CCCA, which tends to almost always affect Black women, FFA, frontal fibrosing alopecia. These are all things that actually can get worse with menopause, but they have specific clinical findings. And if there's a question of it, I would do the biopsy.
Very good to know. All right, now let's get into treatments. And I want to go in order of what you consider the most clinically meaningful first, starting with what you actually do in your office. So maybe starting with PRP, which are platelet-rich plasma. What is it? How does it work for hair loss? What does the evidence actually show? And who's the ideal candidate?
Perfect. So it's so when you look at the treatment algorithm, there's in-office treatments and there are at-home treatments.
Hmm.
And it's a red flag. I personally think it's a red flag when you come in and you see someone for hair loss and they're like, yeah, let's just do some PRP and that's all you're offered. And that's the only discussion that's had. Because if you really want to maximize your hair growth, I always say throw everything in the kitchen sink at it
Yeah.
to a certain extent. Of course, making sure that it's safe and you're a candidate and all that good stuff. So when
Hmm.
it comes to when I see a patient and we come up with the diagnosis, whether it's TE or androgenic alopecia, thankfully the treatment's kind of the same for both. I always start, and I have lots of patients that come to me and they're like, I'm here for a PRP hair consult. And I'm like, yeah, 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 we'll get there. But I always start with at home treatment first.
Mm.
The gold standard treatments are minoxidil, spironolactone, finasteride, dutasteride. These are things that have decades worth of research, whether it's on label or off label, but decades worth of research that they to me are the golden standard. They are the true kernel. They are the fire that we are lighting underneath the hair to make sure that it grows. So I start with minoxidil. What does that do? It actually increases blood flow to the scalp. We don't fully understand how it works, but it increases blood flow to the scalp. It actually induces the hair follicle, the hair follicle that's in the shedding phase, pushes it more into the growing or phase or the anagen phase. prolongs the androgen phase. Lots of ways in which it works. You can use it topically or orally, and we can always talk about what the difference is. But minoxidil, I start with.
Well, here,
I
let's talk about minoxidil and the different
Yeah,
doses and
love that.
the topical versus the oral, because a
Yeah.
lot of women want to do this holistically. And
Yes.
I always say to them, are you wearing glasses or contacts? Are you wearing a hearing aid if you need hearing support, right? Like,
Yeah.
get the support you need that has the evidence behind it so you can
Yes.
get the results that you want. So a lot of women
Exactly.
fear taking oral minoxidil.
Yeah, and I'm grateful for the New York Times article back in 2021 or 2022 that talked about oral minoxidil like it was some new novel thing. It really
Right.
isn't. I've been prescribing it for years. But minoxidil is truly, it's the, if we're looking at like reducing shedding, increasing hair growth, minoxidil is gold standard, top of the line. That's the number one treatment. And fun fact, if you see it, if you're scrolling on Instagram and a company's all their whole selling point is this is better than minoxidil or they're cutting minoxidil down, run because you don't because minoxidil is truly the gold standard. And so minoxidil, we talked about how it works. There you can do it either topically or orally. Topically, there's the 2% versus 5%. There's really no reason to really use the 2% anymore. I'm going to be honest. 2% was reserved for women, 5% for men. Now 5%, even FDA on label wise, at
Yeah.
5% is acceptable for both men and women. And to get the full benefit, it needs to be used twice a day, morning and night. Lots of compliance issues and adherence issues with the topical because it can cause irritation. It messes with the hair texture. Applying something to the scalp twice a day is a lot to do. And as you mentioned, this is supportive treatment and it is treatment that it's long term and it's lifelong. It is long term because it's like brushing your teeth or going to the gym. If you want to maintain your teeth, maintain your physique, you're going to need to keep working at it. You're going to need to keep doing it. You're going to need to keep the routine. So topically, cumbersome, twice a day, affects the hair, can be sensitizing to people, meaning causes irritation.
Hmm.
I would say 99% of my patients are on oral minoxidil. So oral minoxidil, it's a pill, it's easier to take. The dosage ranges, it's new research is showing that with the medication that we have right now, it needs to be taken twice a day, not once a day, but twice a day. And the dosage ranges from 1.25 milligrams up to 5 milligrams in women. The biggest risks, honestly, they've been with the newer minoxidil drug that's going to be coming out, the first FDA approved oral medication for androgenetic alopecia that we have had in 30 plus years, has shown that even with this new, I'm glad, not even just because of the drug itself, but because of the study. The studies show that these low dose oral minoxidil, because this minoxidil, if people don't know, was originally developed as a blood pressure medication to lower people's blood pressure. But I think it was back in the 90s or something. They were giving it to a bunch of hospitalized patients for heart failure for heart failure, I believe, and everyone was regrowing hair, and that's where minoxidil was born. So people are worried about their blood pressure, heart rate, things like that. These are all, and their heart health, these are all very legitimate concerns. But these risks are minuscule, especially in someone that doesn't have any heart health history when it comes to this low dose oral minoxidil. So lots and lots and lots of reports and studies have shown that low dose oral minoxidil doesn't really affect your blood pressure. In fact, I have lots of patients that are already on blood pressure medications taking oral minoxidil doing just fine. If you do have a heart history of any kind, I would get the cardiologist on board
So are you saying for dosing for oral minoxidil, it's starting at 1.25, and you're saying twice a day up
twice a
to
day.
2.5 twice a day or once a day?
Twice a day.
Really?
Twice a day.
I take 2.5 once a day. I have
Yeah.
actually never heard of anyone taking it twice a day. That's really interesting.
Yeah, so this is hot off the presses in the last like
Okay.
6 to 9 months. So this is I personally just 2 months ago just changed how I take it because I usually take 5 milligrams a day. Now I take five twice a day.
Hmm.
Why? Because they've shown that with this oral minoxidil. So for you, if you're taking 2.5, I would probably start 2.5 and then 1.25 at night. Do that for like a
Hmm.
few weeks and then go up to 2.5 twice a day. The biggest side effects that I caution people about is like excess facial hair. Most of the time, if you're dosing it correctly, it's just extra peach fuzz. But if you get a lot of facial hair and it's annoying, the good news is we cut the dose down. It's what we call dose dependent. We cut the dose down. The excess facial hair goes away. So if you get side effects from minoxidil that are not nice or not good, we cut the dose down and the side effect goes away.
Let's talk about
Um,
dread shed because
yes,
that is
yes,
something that lots of women don't know about and lots of their derms do not tell them about. They just sort of forget it. And then the woman is 3 weeks in and she calls me panicking. What the heck is going on? My hair is just
yeah,
falling out. I'm not going to have any hair left. And it's a
yes.
real panic situation. And I also want to know if you're saying you could double up your dose or do 2.5 and then I could add 1.25. Is just changing that little dose also going to trigger some dread shed?
Great question. So what is dread shed? So dread shed it happens. I forget I don't think they have actual numbers, but in my experience, I think it's at about 5% of patients or less that take minoxidil either orally or topically, and they experience what we call a dread shed. So they experience a worsening of the hair shedding for a few weeks or a couple of weeks. It's anywhere between 2 to 6 weeks before it gets better. It's happened to my patients. It's happened to my own mom who's called me freaking out. And
Me too.
yeah. And so it's unfortunate, but the good news is there is some evidence that shows that the people that are experiencing this dread shed actually get the best results from minoxidil. So the worst thing that you could do is actually stop, because you're going to have to restart it anyway, or you're going to have to go through this shed. So what I
Hmm.
tell patients is if you are experiencing this shed, you can temporarily for like 4 weeks. And this is all anecdotal. There's no studies on this, I don't think. Last time I checked, but I've seen this help. And maybe it's a placebo thing. It's a manifestation thing. I tell patients double your dose for 4 weeks. Almost everyone says it works. So if they're on 2.5, I tell them take a 5 for 4 weeks. If you experience that shed, it'll stop it quicker, and then you could
Hmm.
just go back down. And I haven't had a single patient in several years that I can recall that actually stopped minoxidil because of the dread shed.
Interesting.
However, to answer your question about what if you're already on it and then
Hmm.
you add that extra dose, I wouldn't worry about the dread shed whatsoever.
Hmm. Okay. Really
Yeah,
good to know. All right, let's talk about finasteride because that's another big one, and I'm also on that. I take oral
yeah,
finasteride. I take the highest dose of 5 milligrams a day.
yeah.
So talk about finasteride and topically and orally and what it does.
So finasteride works differently than minoxidil.
Mhm.
Minoxidil, we think it works on blood flow, actually stimulates the hair follicle. Finasteride is what we call like an anti-hormonal or anti-androgen, I should say. So it blocks the conversion of testosterone that we talked about to dihydrotestosterone. There are two forms of this, finasteride and dutasteride.
Mhm.
Finasteride, it's, as I mentioned, and dutasteride, they block that DHT, hence lowering sort of those DHT levels, theoretically, leaving all the rest of your testosterone intact. So it's protecting from that genetic hormonal component that we talked about. And so it's not always used in cases of chronic telogen effluvium where I just can't get them under control. I'll use finasteride and dutasteride. However, it's true niche. Their true niche is in androgenetic alopecia. What's the difference between finasteride and dutasteride? I think of do like two. So dutasteride works on two enzymes. Those are the proteins that convert the testosterone, and finasteride works on one. And I'm glad you're on the 5 milligrams because studies have shown that the 1 milligram that is marketed and works for men actually
Yeah.
doesn't work for women. Women need a higher
Right.
dose, anywhere between 2.5 to 5.
Right.
And the side effect profile is much less with these medications, meaning less issues with like heart rate, which you can happen with oral minoxidil that tends to go away on its own. No, they don't have any heart side effects, I should say, or any heart risks. But there is in men and both women, like this is something that is not talked about in women, especially postmenopausal women. We want to keep an eye on your libido or your sex drive.
Yeah.
It can affect the sex drive. It can affect energy levels. It can affect mood. I've had a patient that she said she took the finasteride and she swears it made her depressed and she stopped and went away. These are all real things, extremely rare, but everyone needs to know about, everyone needs to be counseled about. And the good news is if you take this, get a side effect, stop it. Within a couple of days, everything goes back to normal.
Right, exactly. This is where working with a healthcare team who can really help you balance all of the hormones you're taking, right? Your
Yeah.
hormonal menopausal therapy, including testosterone. So it's that fine dance between the right dose of testosterone where you feel good and you have some libido, and the hair loss medications so that you can feel really good about your hair and
Yeah.
sexy and all the things that you want to feel, so you're not stressed out about it.
Exactly. So it's balancing the medication that you need with treating a potential side effect of the medication.
Right.
So it's truly a balance, and we do it all the time.
And women should know that this is not an overnight equation. It could take
Yeah.
some months to really get this right for you. I've
Yeah.
been on all of these medications for many, many years. I've been on testosterone replacement therapy for over 25 years. And it's
Mm.
not something that I'm willing to give up, but I'm also not willing to give up my hair loss. I mean, my hair
Yeah.
growth.
Yeah, absolutely. And I'm
Yeah.
in complete agreement.
Yeah. What about spironolactone? That's something that I tried. That's an anti-androgen also used in women. Something it did not work for me. I know some women it really does work for them.
Yeah, so spironolactone I use in women that are premenopausal or of reproductive age. I use that before finasteride and dutasteride,
Hmm.
just because it doesn't affect reproduction whatsoever, but you really have to be like extra, extra, extra careful not to get pregnant because you don't want it to affect the baby and the hormonal development of the baby. I'm
Hmm.
referring to finasteride and dutasteride. Spironolactone, less of a worry. Definitely should not get pregnant on it. But spironolactone, instead of blocking the conversion that finasteride and dutasteride does, it works by just protecting the hair follicle, like blocking it at the
Hmm.
receptor level. And there are really great studies comparing Spiro versus dutasteride and finasteride. My gut feeling is finasteride dutasteride work better. But spironolactone still has its place, as I mentioned, in women of reproductive age. It is, again, it's like minoxidil. It was developed as a blood pressure medication at first, even though it's kind of a lousy blood pressure medication. It doesn't work all that well, but we still have to, counsel about that. So I call minoxidil, spironolactone, and dutasteride or finasteride. I call them the three musketeers of hair loss. I have patients that are on combination of either or. And I have
Right.
patients that are on all three. I have patients
Hmm.
that do certainly well on minoxidil and spironolactone. You add the dutasteride, they get even better improvement. So it's
Yeah.
not a one size fits all.
Yeah, not at all. Let's talk about some of the other topicals. There's some compounded pharmacies online where you can get a mix of different things, latanoprost and cetirizine, melatonin, caffeine, biotin. How do you
Yeah.
position a formula like this relative to a compounded like minoxidil, like an
Yeah.
82M or an 82F or an 82D?
Yeah.
So these are cash pay, not covered by insurance. And what I like about some of them, well, I use one called 82M, is that it dries on contact on my scalp. So like Rogaine or Propecia, there's no oily feeling, there's no interference in styling my curls. It's very easy to use. But again, you have to
Yeah.
use it every single day for the rest of your life.
Exactly. And so you touched on a couple of different things when it comes to these formulations. Is one, how cosmetically elegant is it? So it's cosmesis. And two, is it actually effective in what's in it?
Yeah.
So when you look at these ingredients, and this not just applies to these formulations, it applies to anything that, and the question I always ask myself, is it better than minoxidil? Prove to me that it's better than minoxidil. So there is evidence that caffeine and bimatoprost and latanoprost and all of these cetirizine, all of these ingredients can help with hair growth. They have much less research. And when you really look at them in comparison to minoxidil, do they really add much to the picture? I don't know how much that we don't know the answer to that. But if you feel like if you're not on any of these things and you're on what things we discussed, don't feel like you're missing out on anything. The
Hmm.
one that I will say there is more robust evidence, and I think it's in the 82M is when we combine minoxidil with a retinol or retinoic acid.
Hmm.
The retinol causes, it actually works via two mechanisms. It actually improves the health of the scalp over time because what we've seen is the scalp actually ages. So this is not just a hair condition, it's a scalp condition too.
Hmm.
The scalp ages and it affects, you get oxidation, you get loss of collagen, elastin, all of these things can and will contribute to hair thinning and hair loss. So the retinol helps reverse that.
Yeah.
Also, physically, the retinol helps cause a little bit of like micro irritation that causes the minoxidil to penetrate deeper. And
Hmm.
so it works via two mechanisms. And these compounded retinols and retinoic acids with minoxidil have the most sort of track record behind them. And I've seen patients notice a difference. But like you said, you have to use it every day. And the bigger issue is the retinoic acid or retinol. Not everybody can tolerate it. For some
Right.
people, it can cause irritation. And if that's the
Yeah.
case, I tell people to use the retinol or retinoic acid formula like 2 or 3 times a week, and then go
Hmm.
back to your regular topical minoxidil the other days of the week. So again, you'll have to balance side effects with efficacy.
Right. So as people are hearing this, this is a routine. This is a daily routine for the rest of your life. And you are either going to be in or you are going to be out, but there is no gray zone here.
Absolutely. Absolutely.
Let's talk about rosemary oil because there is genuine emerging evidence on this. And what does the research actually show? How does it compare to minoxidil in head-to-head studies? And how
Yep.
should women be using it?
Rosemary oil it's emerging because it's getting dug out of the vaults. These
Hmm.
are very, very old studies that compared minoxidil to rosemary oil to 2% minoxidil. Um, it was just as effective as 2% minoxidil. They didn't compare it to 5%, so 5% would be better. So if you're going to reach for the rosemary oil, skip it, reach for the minoxidil instead.
Good advice. I love that. All right, let's circle back to in-office treatments like the
Yes.
PRP and exosomes. And one of my personal favorites is the Alma TED. So start with platelet-rich plasma. Again,
Yeah.
what is it and how does it work for hair loss and who should use it?
So, platelet rich plasma or PRP, out of all the in office treatments, has the longest track record and the most robust research behind it. It is a procedure where it was made famous back in the day because it was like it's used in the vampire facial.
Yeah.
But it's a procedure where you come in, they draw your blood, spin the blood down, they separate your platelets, which are very light yellow color, from the actual red blood cells. So, the red blood cells you toss out, we don't need. You keep your platelets. They contain all the growth factors, and they take that and they inject it back into the scalp, or they microneedle it into the scalp. And keep in mind that with all of these treatments, we can't say that, okay, this is FDA approved or this is used for this. It's cleared as a microneedling, as for microneedling. It's really, there's no FDA approval for any of these things.
Hmm.
But there is evidence that they may work, may not work. We'll talk about that. But just regulatory wise, these are not FDA approved treatments whatsoever. We might be getting one that's exosome based, which we'll talk about, which I'm super excited about.
Mhm.
But with PRP, again, they draw your blood, inject it into the scalp or microneedle it into the scalp. The regimen is you do it once a month, 3 to 4 times, and then one booster shot, usually every 6 months after that. And again, that needs to be maintained. How does it fit in? I treat all of these treatments as adjunct treatments. So it's almost like the medications that we talked about start the fire. This is like adding gasoline into the fire. It can boost your results and speed up your results. And there were studies that compared PRP alone to minoxidil. Some studies showed that the PRP is better. Some studies show that they're just as equal or just as effective. And the reason probably why the evidence behind PRP is so all over the place sometimes is because not all PRP systems are the same. They're not all prepared the same. I can see you this month, draw your platelets, and you can have beautiful platelets because you're hydrated and your nutrients, blah, blah, blah. And then 2 months from now, your platelets can be not as good,
Yeah.
not as robust. You can be dehydrated. And so even in the intrapersonally, so within the same person, your platelets could look different now than they are in 3 months.
Yeah.
And so treatment can vary, but it is great for patients that are just like, I don't want anything but my own. It still works. It still has its place. That's where PRP comes in. Um,
Yeah.
Sorry, go ahead.
I was going to ask if somebody comes in and they say, I absolutely don't want to take any medications. I want a very
Yeah.
holistic protocol, and
Yep.
PRP to them is holistic. Is that a
Absolutely.
standalone?
Yep. I certainly have patients that don't want any medications or anything
Yeah.
synthetic, whether topical or oral. And yeah, and I've seen patients that are very happy with PRP and I still see them. But I tell patients, and these are not just these patients, but I tell all hair loss patients is not everybody responds the same. Our goal is to do the best we can, throw everything at it that is within reason and within your comfort level and within your safety, of course. And we light a candle and say a prayer. And that's what I tell patients. But yes, as a standalone, yeah, I have a handful of patients that use it as standalone and they've seen improvement.
Talk about the realistic picture of pain involved in this. You mentioned
Yes.
microneedling. So I had PRP probably 10 years ago. I went through once a month for 3 months and a booster after 6 months. And it was very painful. It was because it was so long ago, we didn't, there weren't protocols to help numb my scalp the way there are now. But
Yeah.
it's a real, there is could be significant uncomfortableness to this depending on who you go to and what they're using.
Absolutely. In general, and we'll talk about exosomes, but in general, PRP is more painful than exosomes, especially if you're injecting it. But
Yeah.
if you're the microneedling into the scalp, I don't personally do it. There's sometimes, and there's reports that sometimes it can make the hair loss worse, and I don't even want to take that risk. And so yeah, it is painful. And when I inject, there are a couple of different ways that you can use that you can numb the scalp. One is with injections around the scalp to
Hmm.
help numb the scalp. But if I'm doing injections, I'm just like, let me just inject you once because even the numbing injections, they're painful in and of themselves. So I
Right.
will just go right at it. The ways that you can numb while you're injecting is with cold air blowing,
Hmm.
ice. So you ice, inject, ice, inject. They interestingly, and one of my friends, she published on this. You can use those vibrating tools, but in some patients it actually helped, but in some patients it actually made the pain worse. So I use
Hmm.
icing and cooling, and if the person knows what they're doing and they're quick and swift, the question I always get is how long does the injection take? About a minute and a half. Like it takes me a minute and a half to do the entire injection procedure. Again, not FDA cleared, not FDA approved. We discussed risk, but if I were to inject the scalp, allegedly, it takes me about a minute to a minute and a half. It's pretty quick. And um, to juxtapose with, and the reason why it's more painful than the exosomes and whatnot, because the needle is a little bit bigger, because the PRP can be a little thicker and sludgy. So you need a
Hmm.
bigger needle. But exosomes, you can use that little 30 gauge needle that's almost like an insulin sized needle, and it's much quicker and it's much less painful.
Hmm. So talk about exosomes. How are they different from PRP, and what does the current evidence show with them?
So exosomes are what PRP was like 8, 10 years ago. So exosomes are
Hmm.
the next frontier. What's the difference? They come out of a vial that came from a lab. So exosomes are what we call vesicles. So you remember the growth factors were in the platelets. These are little vesicles, these little bubbles, these little balls that have growth factors in them. And where do they come from? So they can come, and they usually come, they can come from plants, which we don't really use much. Whenever you see exosomes in products that are over the counter, they're usually plant
Hmm.
derived. But usually in the clinic, we get them from other humans. And usually these, you have to make sure as a clinician, if you're going to offer this treatment, you have to go to a lab that is cleared, at least by the FDA, that it has been inspected, because what you could basically they source these exosomes from younger patients that need to be screened for diseases and conditions and make sure that they're healthy. And these exosomes are sourced from other patients, either their fats, there are stem cells, or they can be sourced from bone marrow, or they could even be sourced from amniotic fluid and umbilical cords. And so there are debates of like which one's better, which one's more inflammatory. This is all new research, and this is all not FDA cleared or FDA approved. It is
Hmm.
FDA cleared. Exosomes are FDA cleared for microneedling onto the skin. I think it's the face and the scalp, I believe, not for
Hmm.
injection. But exosomes, The reason why I'm excited about exosomes because you get high concentration of these growth factors,
Hmm.
way less painful, and and if it's coming from a reputable lab, from its and these are not compounded; these are actual manufactured products that have been tested. You're getting exactly the same treatment every single time. And as I hinted, there is hopefully in the next year, we're going to be getting the first FDA approved exosome injectable for the scalp. And they've actually not rushed, they've actually fast tracked some of their studies, their safety studies, because their results are showing fantastic results. And right now it's FDA cleared, or I think maybe approved for microneedling, but soon it will be approved for injection into the scalp. So I'm very excited. Exosomes are the new frontier.
Yeah, that is really exciting. So exosomes compared to PRP in terms of how often you have to do it, what's the difference?
Good question. So the most exosome treatments that are out there right now, it's the same monthly for 3 times and then one booster every 6 months. But this newer one that is going to be coming out, it's so potent that actually you do it once, wait 90 days, do it again, and then you could boost it every year from there. So the newer super high concentrated ones can actually be extended even longer, but most of them are about the same monthly 3 times and then once twice a year.
So you bring up a really good point. Sometimes people think that if their hair growth is stable because they're doing things, that they don't need to go back and do PRP or exosomes if that's something they were doing before.
Yeah.
I'm in the camp of if you find an equation that works for you, repeat it
Stick with it.
every year. Stay ahead of the 911. Just build it
Yeah.
into, I always say, you have a skincare routine bank, you have a hair growth bank or budget, right? What's your budget?
Yes.
And just build it in, which leads me to the Almond Head, which is a device that I have come to absolutely love over the last 3 to 4 years. Could you
Mm.
talk about Almond Head and what it is, why it's pretty exciting and pain-free?
Yeah. So the biggest draw for the Almated is what you had mentioned is the pain free. And I've tried it
Yes.
myself. So how does it differ? So they still use growth factors. The biggest sort of question with Almated and all these devices and all these procedures, sorry, is what growth factors are they? Where are they getting from? So the
Yeah.
question remains the same. But the difference between the Almated device and the other ones is it uses ultrasound and I think forced air to actually push they've actually shown ultrasound to actually push the growth factors into the skin. And this
Hmm.
is not new technology. It has been shown that ultrasound can be used to push things into the skin, which is great because I personally had the procedure done. It feels like a scalp massage. I absolutely love it.
Hmm.
Does it work for everybody? No, but like everything else, it doesn't work for everybody. But it's done, I believe, once monthly. I think it's the
Hmm.
same once monthly 3 times and then once every 6 months.
Right.
Yeah, and it's part of that arsenal of like adjunct treatments. Now, I have patients that are like, should I do both PRP exosomes and everything if budget is not a thing? No, I actually have. I've seen a case where the patient was loving the hair growth, and we were doing and and not by me, but I found out she was like bouncing around. She was getting PRP once a month for a year. And actually, too much of a good thing is bad. Actually, the hair loss got
Hmm. Hmm.
worse. And so
Hmm.
you really want to balance what you're doing treatment wise and you don't want to overdo it.
Yeah. Let's talk about red light therapy because there's
Mhm.
a lot of great clinical evidence behind red light therapy for our hair follicles that differ from our face. And so, can you talk about lasers versus diodes and the efficacy in home versus at home devices and what that looks like?
So, low level laser therapy or red light therapy, there is significant evidence. There's good evidence, even better than the face, actually. There's
Right.
better evidence that it actually works on the hair. And we don't fully understand how, but there's a belief that the light actually energizes the hair follicles and the stem cells and stimulates the mitochondrial activity, which is the powerhouse of the cell. It generates energy and helps it grow and act younger and fuller. The biggest drawback and the biggest thing that people should know with these low level laser therapies, these red light caps or masks or whatever it may be, is they need to be used exactly as directed for at least a year to get the full benefit. So you can't do it a couple times a week. You're wasting your time and we're wasting your money. So that means when you're going on your week long or 2 week long vacation, you're packing this device.
Hmm.
And so if you're down to do that, I say do it. What's the difference between in-office laser therapy versus at-home laser therapy? I think the devices have gotten um, uh, advanced enough that you can do it at home, and
Yeah.
there's really not much difference between in-office and at home.
Well, that's
And then
good to
the
know.
answer is consistency at this point.
Yeah. Yeah. So I am that person that takes my red light therapy cap on vacation with me.
Yeah, good for you.
Yeah, yeah. I mean, if it's 2 days, if it's 5 days, if it's 10 days, it is coming with me. It's just part of my protocol. And, from a health coach perspective, and I work with people on lifestyle interventions and creating routines that work for them, that they're really going to commit to and stick with. It's just like you said, it's like brushing your teeth. It's like doing anything else. You just start to work it in. And in the beginning, it's going to feel cumbersome and uncomfortable and
Uh,
annoying and frustrating. But by week 6 or week 8, it's just going to be one of the things you just do. You get in bed, I put on my 82M drops on my scalp, I get into bed, I put my red light therapy cap on for 20 minutes, I read, and I go to bed. And it could not be easier.
Absolutely. It's like building a habit like anything else. Eventually it'll
100%.
become routine, but I
Yeah.
do I do see especially it's how long do they say it used to be 6 weeks? Well, how long does it take to build a habit now? Is it like 3 months or something?
Yes, it's 3 months for
It's
sure.
3 months. Yeah,
Hmm.
that's what I figured.
Right.
So
And
it's doable.
the hardest part is, especially with hair growth, is it takes a really long time to grow your hair.
Yes.
And
I'm
so the
glad.
buy-in is really hard because if you're doing all these
Yes.
things and you're throwing this equation at you and you're 3 months in, you just went through a dread shed, you're feeling really, bad about yourself and the way you look and how it feels, on your hair, on your head, it's hard to buy in that the results are going to be there, but not for 12 months.
Exactly. I'm so glad you brought that out because the question is always like, when do I start seeing results?
Yeah.
I tell people like watching hair grow is like watching grass grow. Like,
Yeah.
don't even bother watching it. And in
Yeah.
fact, my patients that are like, oh, I took my scalp once a day or once a week or once a month. I tell them you're just causing more stress on
Yeah.
yourself that you could be making your hair loss worse. So if I see a patient that for the first time and we're doing hair and we're not doing any treatments and we're just doing medical treatment, I tell them you might notice something at 3 to 4 months, but I don't see them until 6 months. And I think it's very important, especially for clinicians, that you're getting photos. Now, don't go like you
Yeah.
could take your own photos, but weekly photos, not even monthly photos. Don't go crazy. Maybe photos every 3 months, but I take
Right.
photos at baseline and then again at
Yeah.
6 months.
Yeah.
And then we see what's working and what's not and what we need to adjust. And one last thing I wanted to mention about like in office versus in home treatments, let's be realistic. I don't know how many patients, but like a lot, if not most patients, just these in-office treatments are not in their budget. And so
Right.
don't feel like that you're missing out on anything if you are taking these medications and you're feeling bummed that you can't afford these treatments right now. That's absolutely not true. What's
Right.
actually mostly doing the heavy lifting are these tried and true three musketeers of hair loss. So don't
Yeah.
feel bad. And they're generic medications, things, there's ways around getting these medications in your hand.
100%. So I want to spend some real time on this section next because this is where women are spending a lot of money and getting very little direction or results. The social media hair loss space is absolutely flooded right
Yes.
now. And most women are buying things before they have a diagnosis, before they've met with a dermatologist like yourself, before they know what type of hair loss they have. So I wanted to go through some of these options that are out there. The one category that sticks out to me is scalp serums, and there are so many now. It seems like every hair shampoo kind of company or cosmetic company is also coming out with a hair serum. So where is the red flag? How does a woman know, should we try these? Should we not?
Great question. So when you're looking at something, especially if it has a hefty price tag, browse their website, put their website and their brand name into AI, into Claude or ChatGPT, and scour for some evidence. ask for, is there any evidence of are there any published research, present published results, presentations, anything like that that shows that this actually works? That, and if there's nothing out there, that's red flag number one. Red flag number two, if it's crazy expensive and if it comes
Hmm.
from a big luxury brand and the bottle's beautiful, again, you're paying for all of that. A lot of what these scalp serums are doing, and I'm liking the direction they're going, is they're high in antioxidants like zinc and niacinamide and vitamin E, because like I mentioned, the scalp is aging. And so targeting the scalp health is something that's new, and I'm loving the direction we're going. There's a brand called Nulastin, Nulastin, that is targeting elastin in the scalp that no one's doing. And there's elastin, not just collagen, but elastin loss in the scalp, which is exciting. So, and companies like Nulastin and OneSkin is another one that actually have evidence behind them, then they might be worth the price tag. But if it's just a lot of hoopla and there's no evidence, I'd say, take a step back, but also be very realistic with yourself. Ask yourself, am I actually going to stick with this scalp serum? Am I actually going to do it? And if you're like, yeah, I apply serums on my face all day, I'll apply it to the scalp, have at it, go at it. And this is just this, again, not a standalone treatment, but keeping your scalp health healthy. I'm all about addressing the scalp as well. So I'm loving the direction they're going, but have a discerning eye when it comes to what you're being marketed at.
Because the women online who are selling these serums to women my age, they're in their 20s and 30s with gorgeous hair. Some of
Thank
them
you.
are even trichologists, and I love trichologists. But I
Mm.
do feel like there is this movement going on Instagram, especially with these young trichologists who are pushing these from Dove, from Neutrogena, from Pantene, and I just don't know if this is where we should be going.
I agree. So there's the one side, the evidence, the science. Like,
Yeah.
yep, the scalp it needs TLC, it needs antioxidants, needs health and anti-aging and moisture, and a lot of these antioxidants and peptides and ingredients do help the scalp. But then on the other hand, the reality of Instagram, it's so not regulated, and Instagram and TikTok and all this social media, there's
Right.
so not regulated. People can just say, oh, it's regrew all my hair, and it could be completely untrue. And
Mhm.
there's no one checking them, and there's no one fact checking this. So it's the wild, wild west out there when it comes to messaging and communication. So, yeah, I completely agree. And take a step back, and just, if it's too good to be true, it probably is.
But this is where building a healthcare team is so important, and including
Yeah,
someone like you on your healthcare team if hair loss is an issue for you, because you can go to you. I could go to you and say, hey, what do you think about OneSkin versus Dove in terms of serums? And you're going to
yeah,
tell me. If you want to do it and you don't need to, pick this one. So,
yeah,
just making sure we have that evidence and that support. Let's move on to hair growth shampoos because this is another category that we are being marketed online.
yeah.
Does shampoo matter? When does it matter and for who?
So if you have any flaking, dryness, scaling in the scalp, itching in the scalp, anything like that, anything that can suggest dandruff or seborrheic dermatitis, which
Hmm.
is the more severe or the medical term for it, you need to treat it with an anti-yeast or antifungal shampoo like Nizoral or ketoconazole that comes in over the counter or brand or prescription. Selenium sulfide like Selsun, Head and Shoulders, one of my favorites. People think I'm crazy and patients look at me weird when I'm just like, Head and Shoulders is probably the best shampoo you could ever use
Mm.
because it's got zinc parathione in it, and actually zinc has so much evidence that it's an antioxidant, helps with scalp health, with hair growth. So I use Head and Shoulders like nobody's business. I love Head and Shoulders. But if you have any signs of inflammation, like itching, flaking, dandruff, itching and scaling in the scalp, you want to treat that. Why? Because even that low grade inflammation can accelerate hair loss. That's been shown. That is where I'm strict with your type of shampoo that you're using is if you have scalp symptoms. But
Hmm.
then when it comes to scalp regrowing shampoos, I think they're even less important than serums. Why? Because you need to rub it into the scalp, let it sit for at least 2 to 3 minutes. Most people don't do that.
Right.
And even then, the penetration is not as great as a leave-on serum. And they all kind of have the same things. They're biotin antioxidants, like zinc. Some have caffeine. Some have other ingredients. All of these antioxidant ingredients that can possibly help in serum or shampoo form. But again, if you're treating it holistically, and if you're just like, oh, I don't want to see a doctor, I don't want to take any prescriptions, I don't want in-office treatments, I
Hmm.
don't want medications, then yeah, invest in the shampoo and the serum. But if you're doing all these other treatments, it's a drop in the bucket, to be honest. It's a drop in the
Yeah.
bucket. And Head and Shoulders is cheap, and I'm not getting paid by them or anything. I just love Head
Right.
and Shoulders.
Oh, it's great. It's a great call out because people need to walk into Walgreens or CVS and know that they can also take care of themselves this way too. We need to have a plethora of options. We all come from different budgets and
Yeah.
align with different ways of doing things. And so I think that's great. What about minoxidil gummies? This is
Yeah.
becoming pretty popular online from, I know of one telehealth company that is doing it now. So it's a kind of a new delivery format. What do you think of the bioavailability?
Yeah. So I did some research on this because I admittedly didn't even know
Mm-hmm.
what the difference was. And I was researching it last week. It's the same drugs, same dosing and everything, just a new, more palatable way to take it. Like it's in a gummy form, much easier to take. I don't know if you've ever had the minoxidil tablet sort of dissolve on your tongue. It tastes awful. So I'd be really interested to know what the gummies actually taste like. But the issue is these are compounded. What does that mean? There's a lab somewhere, they're crushing it in, they're crushing the
Mm,
pill, putting it in the gummy. And so how do you know? You actually don't. The answer is no. Spoiler
hmm,
alert, the answer is no, you don't know. But how do you know that you're getting exactly 2.5 milligrams per gummy? How do you know
mm,
that it's actually getting absorbed? What's happening to all that sugar and stuff that's in the medic? So we don't have data on bioavailability. We don't have data on, there's no, like, if this is a medication or it's a drug that is FDA monitored, then you know every single pill you're getting the same dose. You just don't have
yeah,
that with the gummy. So they need studies. I know the studies don't exist, but they just don't have any. Safety wise, I wouldn't be too concerned, especially at those low doses. But efficacy wise, I wouldn't. I personally wouldn't take the risk of, risking my hair loss regimen just to get a
yeah,
gummy instead. That's not well established.
yeah, I agree. So I want to end on the frontier of hair loss treatments because I think it's genuinely exciting and gives women hope that this field is really moving fast and growing and becoming more accessible. So you did mention the new oral minoxidil pill that's in development. That is generating a lot of significant attention. Do you want to talk about it a little bit more and how it's going to differ from what we have available now?
Yeah. So the oral minoxidil, again, it's not a new and novel drug. It's the same drug, but it's packaged differently. It's packaged as a pill because what we've seen, and this is where that whole twice a day comes in,
Mm-hmm.
the whole twice a day regimen comes in with the current pill that we have, is because it is quickly absorbed and it quickly broken down by the body. And they've shown that actually the effectiveness, the hair, the what we call, I forget what that zone is called. I'm forgetting my pharmacology, but that area where the time where the minoxidil is actually effective, it's only about 8 to 9 hours. So you're technically, if you just taking it once a day, you're only treating your hair for about 8, max 12 hours. And the
Hmm.
other rest is not. So this is a higher dose minoxidil, but much a slower release. So you're getting it into your system in that therapeutic zone. That's what we call the therapeutic zone. You're getting it much slower release, much longer time, so your hair is seeing and being exposed to that active minoxidil for much longer. So this is a once a day formulation versus need to take it twice a day. And when it is slow release like that, they've shown that you have less acute cardiac side effects. So there's a lot of patients,
Hmm.
not a lot. Some patients, they say that when I first take it, I get like my heart
Yeah.
races a little bit because it like shoots up. It like if you spend, like I mentioned, if you take that minoxidil pill and it spends a little too extra time in your mouth before you grab your water, it dissolves pretty quickly because it hits the system quick and it goes away quicker. This is a
Hmm.
much slower release. theoretically less side effects. We'll wait until we see what the full data shows.
Hmm.
No evidence of cardiac issues or fluid issues, nothing like that. So really good side effect profile. But I think the true winner here is how the delivery mechanism, how long it's staying in your system.
Okay. And then hair banking is something that I came across recently, this concept of banking your follicles or follicle stem cells for future use. Where does this technology stand currently for women? Because when I think about this, I think about men who are mostly getting the FUE treatment
Yeah.
for hair growth.
Yes. So the hair banking, how it's done is there's a couple of people that do it, but Acorn is probably the one that does it for the longest amount of time. And I'll tell you what's super exciting. But basically, they take like a few hairs. I forget how many. Maybe it's 50 to 100 hairs from back here. And they put it in their little tube. They send it to their facility that is FDA cleared, of course, and they actually whittle it down. They extract your growth factors and your stem cells. They take them out of that hair and then they send them back to you. And you have tubes of your own stem cells. And
Mhm.
I forget how long you can bank them. So this is like PRP on steroids. This is elevated PRP. It's not just taking it and just injecting it. It's refining it and processing it and actually multiplying it. And the exciting part, yes, it works for hair and for skin, but the exciting part is they're going to start using it for joints.
Mm.
They've been able to, and this doesn't only have to do with hair. They've been able to regenerate cardiac cells from this. They've been able to regenerate neurological cells like neurons. They've been able to regenerate cartilage from these cells and muscle. So that's really where the exciting part is. And the younger your hair is, the younger you
Hmm.
are, the better the stem cells are that are banked. When it comes to hair specifically and how this compares to PRP versus exosomes versus that, we just don't have data on what's better and what's not. We just don't. But the really exciting part is having your own stem cells
Yeah,
banked for who knows, you might need them down the line. Of course, it
right.
depends on what we can do and where we are technologically speaking, but that's really what I'm excited about.
Yeah, that is really, really cool. Anything else coming down the pipeline that you want women specifically to know about for hair growth?
There's going to be a new topical, a new anti, because we didn't really talk about like topical finasteride, topical dutasteride, these
Hmm.
anti-androgens that we take orally. Now we're starting to see them being used topically, but again, all by compounding pharmacies. But
Hmm.
it's going to be FDA approved. It's a topical that is a topical anti-androgen. So technically, theoretically, I haven't seen the data. I can't wait to see the data. It's something that you apply to your scalp. It blocks the hormones without you having to take an oral pill and risking that it contraindicates or interacts with your HRT or whatever it may be or side effects. So this is promising and it's hopefully going to come out in the next year or two, but it's going to be a topical anti-androgen that is not oral. So that's coming down the line.
So how is that going to differ from something like Formula 82F or Formula 82D?
So with the topical finasteride,
Yeah.
so topical finasteride, we don't know exactly what percentage it is best absorbed. Some of them have 0.1%, some of them have
Hmm.
0.3%. Not studies, but reports are showing that 0.3% is better than the 0.1%. And also delivery mechanism. So they might just be grabbing the finasteride, throwing it in like a solution and putting it on your scalp. How do you know it's getting absorbed? What I'm hoping, and I got this question because I posted about this on social media. Someone was like, "How does this differ from topical finasteride?" What I'm hoping and praying is they have a novel delivery mechanism where they can definitively say, "Okay, this is actually penetrating into the scalp." Because
Hmm.
the less guessing game, the better. So if they can
Yeah.
show that it is actually doing something, penetrating, and if it's going to be FDA approved, we're at least going to have efficacy results. And so that's really the most exciting part because you don't know if the topical finasteride is actually getting through or not. And I say if
Hmm.
it's gone through rigorous testing, I'd rather go for that.
Yeah, for sure. So, if a postmenopausal woman listening to this right now has been losing her hair for 2 years, maybe she's been dismissed by multiple providers and she just doesn't know where to start, and she really is noticing significant hair thinning, what is
Yeah.
the first thing you want her to do this week?
I would do some research, see a board certified dermatologist. And if a dermatologist, and I am going to call out dermatologists, and I've seen this before, if the dermatologist doesn't look at your scalp or doesn't look at your hair and says, hey, says, okay, just use Rogaine and walks out, that's not appropriate. Like if you're not getting the time and the attention and the respect out of that hair loss visit, then I would say find a new board certified dermatologist. But you really, really need a diagnosis first because, like I mentioned, there are other types of alopecias and hair losses out there that you don't want to go missed. And if your current dermatologist is, if you feel dismissed by your current dermatologist, which is very rare, dermatologists, we are doctors of skin, hair, and nails. But if that does happen, or you feel like that does happen, you are well within your right to ask, okay, do you know of a dermatologist or of a provider around that does specialize in hair or hair thinning or hair loss? And so I would say seek a diagnosis, seek the care of someone because they can just guide you through it. There's a lot of
Yeah.
noise out there. It's a multi-billion-dollar industry for a reason. There's so much noise that seeing a board certified dermatologist helps you cut through all that noise.
Yeah. Dr. Omar, thank you so, so much for your
My pleasure.
expertise, your time, the way you explain things so that we can understand what our next steps might be is just so genuine and so appreciative
Appreciate it.
because it's really hard to understand a lot of things, especially when you're in the throes of hair loss and panicking and sad and frustrated, and it's the worst. It is. I
Absolutely.
have been there for many, many decades, and I now know my
Yeah,
equation. I know what to do. I'm sticking with it. And it's a routine
absolutely.
like we talked about, but really hearing from you the red flags to look for, the questions to ask for, the safety and efficacy of the medications that are truly the gold standard is just wonderful. And I thank you for that.
I'm so appreciative of being here and I appreciate your kind words. Thank you so much. It's just what I do and what I love, but I
Yes, you
appreciate
can
you.
tell. All right. And thank you for everyone for tuning in. I know you're walking away with many golden nuggets on what to do next in your hair loss to hair growth journey. And we'll see you next time. Thank you for spending this time with me today. If something in this episode made you think, good, now do something with it. That's what Afterpause is built for. If you are enjoying the podcast, please subscribe, leave a review, and share it with a woman in your life who is ready to stop piecing it together and start moving forward. And if you've seen multiple doctors, spent thousands of dollars, and are still walking away without a real plan and feeling confused and frustrated, I hear you. And I built something specifically for you. You have told me you want answers and direction on your menopause journey without a huge commitment. No 8-week program, no online course, just one focused hour with someone who knows the menopause space inside and out, has spent years building a national network of vetted clinicians, and will help give you a clear, direct path forward. No fluff, no filler, just exactly what to do next, finally. And that's my Menopause Care Consult. One time, 1 hour, and women leave with a real plan for the first time. You'll find the link in the show notes. A quick and important note before you go. By listening to this podcast, you agree not to use anything you hear as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Always consult your own physician for any medical issues you may be having. This applies to everything I share and to every guest who joins me on this show. That said, stay curious, stay strong, and keep showing up for yourself. This is your time. I'll see you next week.